Yeah, it should be one. We're about to broadcast.
Good evening, everyone. I'm T-Shawn Lynch, Assistant Professor of Orthopedic Surgery, and I'm going to be our moderator this evening for our webinar on gymnastics and acrobatics, treating the unique athlete. We have a fantastic faculty this evening. We have Dr. Natasha Desai, who's going to be talking about understanding the gymnast, the unique athlete. Dr. Christopher Ahmad will be discussing different types of overhead athlete, the gymnast, shoulder, and elbow. We have Dr. Amanda Till from Columbia Sports Physical Therapy talking about multi-directional instability of the shoulder, rehab pearls. We have Dr. Ron Lehman discussing assessing and treating back pain in the gymnast. And then finally, Dr. Kubataka will be discussing hip and knee injuries in the acrobat. So that's who we are, and this is who you are. We have over 300 attendees this evening from 42 different states, spending the next hour and 15 minutes with us as we talk about this athletic population. We're going to have 5 talks that will be about 8 minutes each. You'll see on the side of your screen where there's a chat feature, so please feel free to ask questions throughout, and then we'll make sure to have time for a Q&A session afterwards. At the end, please make sure to fill out your surveys to ensure that you get your BOC Category A credit. And again, we use those surveys to help us determine what our next webinars are going to be, as well as areas that we can continue to improve. So without further ado, we'll go ahead and get started with Dr. Natasha Desai.
All right. So thank you all for joining us this evening. I'm Dr. Natasha Desai. I am very excited that you all tuned in to learn more about this very special sport and how to better manage these athletes. So I have no financial disclosures, but I do want to disclose that I was a gymnast for 16 years, so gymnastics is very close to my heart. I competed nationally in club gymnastics, and then I competed on UCLA gymnastics team as well. As you can imagine, I have a very personal investment in improving the care of gymnasts, especially since I've actually had some of the injuries that you'll hear about tonight from my colleagues. When most people think of gymnastics, they think of the Olympics. Every 4 years, a handful of elite gymnasts wow everyone with their gravity-defying routines. What people don't realize is there are actually estimated to be over 100,000 gymnasts practicing and competing every year at all ages and all levels. And there's actually more to gymnastics. There's more disciplines than most people know about as well. There's 6 that are recognized under the Federation of International Gymnastics. The majority are artistic gymnastics. Over 85% of all gymnasts are artistic gymnasts, which is what most people know as gymnastics. So my presentation is mainly going to focus on artistic gymnastics in the following presentations as well. But the same principles tend to apply to all these forms of other acrobatic sport and cheerleading. So when you're going to take care of gymnasts, you need to know the sport structure, at least a basic sport structure. So women's artistic gymnastics has 4 events: vault, bars, beam, and floor. Men's gymnastics has 6 events: vault, high bar, parallel bars, rings, pommel horse, and floor. Each men's and women's has ascending levels of competition. Each level, as you go higher, up to level 10 in the junior Olympic level, which is a more traditional levels, and the newer level system, the Excel levels, as you ascend, you get more difficult skills. You have to string together more difficult skills and routines. And elite is the highest level, and that's the level that you'll see at the Olympics and World Championships. When evaluating a gymnast, it's really important to understand where they are in this level system, especially if they've recently moved up a level, if they're consistently adding difficulty to their routines, which is really important to take into account both in terms of injury susceptibility, but also in trying to get them back from injury. So in talking about injuries, it's reported that over 86,000 gymnastics injuries are treated by medical professionals every year. And I know from firsthand experience, there's probably a lot more that are not treated by medical professionals every year that are self-treated. So it has a level of injury that's equivalent to a contact sport. In fact, an NCAA study found that women's artistic gymnastics had the second highest injury rate in practice compared to all other NCAA sports, only second to football. And it's the 4th highest out of all sports when you combine practice and competition. So when you look at what injuries the gymnasts are getting, you can see that the majority are lower extremity injuries, but there's still a decent amount of upper extremity injuries as well. And then about 13% of the injuries that were recorded in this study were actually back injuries. So when talking about injuries, there's obviously the traumatic injuries. I'm not going to leave that up there for everyone's sake. But just like any other sport, you could break bones, you could tear ACLs, you could get concussions. The diagnosis and treatment of these tend to be the same in routine throughout sport. What gets more sport specific is the return to sport, needing to get back the balance and proprioception, especially in injury like a concussion. What's more unique to gymnastics is the pattern of overuse injuries that these athletes tend to get. The average high-level gymnast practice about 4 to 5 hours a day, about 6 days a week. And in one practice, gymnasts can do a high impact or difficult skill up to 20 or even up to 50 times in one practice. So this constant repetitive nature of the skills can lead to micro injury, and that can build up over time. And when the amount of injury outpaces the amount of healing, that's when you get stress fractures, tendinitis, and other chronic type of injuries. So I'm going to talk a little bit about what makes gymnastics unique. Obviously, that one big part of gymnastics is flexibility. It's part of the beautiful parts of gymnastics. Flexibility is both intrinsic and learned. We're all born with a certain amount of ligamentous laxity or bendiness of our joints. In some cases, it's how tight we are. In the medical community, we measure the ligamentous laxity by the Baton score. And you'll see that most gymnasts have a very high Baton score or very ligamentously lax, meaning that their joints move through a larger range of motion than most people. Then there's also part of flexibility that relies on elasticity of muscle, and that's something that you can actively improve with stretching. Being flexible is an incredible strength to the sport, but it also puts these supporting ligaments and tendons and joints at risk for injury because these joints are going way past the typical range of motion. So it's very important that the opposing muscles and the supporting muscles are very strong throughout the range of motion. The other part that makes gymnastics unique is that it's a year-round sport. So it's important that gymnasts practice their routines and their skills very consistently, and part of it is because of timing. If you can't have a whole off season and be rusty and trying to perform that skill, because if you imagine if the timing is off, it would lead to a lot more injury, as opposed to another sport like baseball. When you're coming back, if you're a little rusty swinging a bat, it's not as bad of a injury. The other thing that makes gymnastics unique is the age of specialization. Gymnasts specialize very, very early. This is me. I'm already competing at age 7, 100% specialized in the sport. The average gymnast specializes by 8 or 9 years old and peaks, and the average gymnast peaks in their late teens to early 20s. And this is mainly because after a certain while, the amount of stresses throughout the body causes a gymnast to reach their maximum ability in the sport. This is really important for a few reasons. Part of it is that when gymnasts are practicing at such high amounts year-round, their growth plates are open during this time. That is a very high metabolic activity area, and the turnover in those areas is very high, and it makes it much more susceptible to stress injuries. Second is we have to take into account that these athletes are very young. There's a large amount of pressure that is placed on very young athletes to be tough, to win, to get back from sport. So it's something to really take into account. Another thing that makes gymnastics unique is we know that gymnasts tend to be petite. Gymnastics doesn't stunt growth, but there is a natural selection for bodies that are smaller and leaner that allows for the agility and the ability to swing between bars and tumble on a 4-inch wide beam. But the need to be small, lean, powerful can put a lot of undue psychological pressure on an athlete as well to attain an unhealthy weight. So it's important to include that there is a high rate of female athlete triad or the spectrum of eating disorder, low bone mineral density, and amenorrhea in females. Up to 68% of gymnasts have been shown to have at least one arm of the female athlete triad. Males can be included as well. It's been expanded to include males that have low weight, low caloric intake, and instead of amenorrhea or irregular periods, they can have low testosterone, and that can make their body susceptible to injuries like chronic stress injuries and overuse injuries. I don't have too much time to dive deeply into this, but we can talk a little bit about it in the Q&A. So last thing I'll talk about is injury prevention. This is something that can be a whole lecture in and of itself, but I just want to focus on some few key areas. One thing is skill progression. It's just really paying attention to how the gymnast is progressing the skill. Are they going too fast? Have they come up accordingly, according to plan, or are they getting pushed to make it, learn a new skill by a certain meet or something like that. Recognizing fatigue, that is a time when gymnasts tend to get injured. So really recognizing that, and maybe avoiding some of the more difficult newer skills. The other things that I'll always say is warm up and stretching before practice is for that practice. Cool down and stretching at the end of practice is really for the future, and that's really for your flexibility training. The last thing I'll say is at all levels, from coaches to parents to gymnasts and then to the medical staff, promoting a really good self-esteem. Happy, healthy gymnasts tend to report their injuries and get treatment sooner rather than trying to hide them and risk further injury. So I just want to thank you guys all for tuning in. I'm really excited. I could talk about this for hours, but I'm really excited for these other lectures. So I'll finish with a big salute like a good gymnast, and I look forward to a lively Q&A session at the end.
All right, way to stick the landing there, Dr. Desai. That was a great introduction there, and as a sports medicine doctor who takes care of a lot of lower extremity injuries, I've been seeing more and more gymnasts as of late, and thank you for kind of laying out a little bit of the progression of these athletes, because I've been learning more and more in terms of the different elite levels and the levels through which they progress through. And a lot of that's been through the patience of my patients to be able to explain that to me. So thanks for laying that great foundation for us. So now we're going to transition to Dr. Chris Vermod. He's going to be talking about upper extremity injuries in the gymnast, talking about shoulder and elbow injuries.
Elbow injuries, very similar to baseball players, and a big part of my practice is taking care of these. And the reason why they resemble baseball players is because they have tremendous force on their elbows from all the repetitive weight bearing that they do, as you see here. And because of that angle of the elbow that you can appreciate, that valgus angle, they get tension on the inside of their elbow that stresses the UCL, compression on the outside of the radiocapitellar joint. And here you see it in an illustration. Tension on the inside tears the UCL, compression on the outside, that compresses the radiocapitellar joint and can create problems related to capitellar OCD. Capitellar OCD is Osteochondritis Dissecans. It happens in young gymnasts, and what happens is the subchondral bone gets weak from the repetitive forces and finally fractures, and the cartilage above it gets loose, and they develop pain, locking, catching sensations, and often lose movement. This area of the elbow, the capitellum, has poor blood supply. So when you combine poor blood supply with repetitive high force, that's what results in osteochondritis dissecans. Huge prevalence of capitellar OCD in male throwers and also female gymnasts. And gymnasts often get it in both their elbows. This is more information on my website. If you really want to learn more about capitellar OCD, visit it. I have research studies, review articles, case examples, videos. Be an excellent resource for you if you want to learn more. Back to capitellar OCD, these patients, when they present, we get an MRI scan. You can see in the cartoon, if the bone with the overlying cartilage becomes loose, it causes the symptoms you see in the MRI scan, and a broken piece that's displaced. Let's talk about a case. This is a level 10 gymnast, outstanding young athlete who developed locking in her elbow with a normal exam. UCL was normal, the capitellum was normal, but on x-ray you see these large, multiple loose bodies. On an MRI scan you see here, there's two in the front, one in the back. And we treat this very effectively with arthroscopy. The camera is placed inside the elbow joint. You can see the two loose bodies just as they appear on the MRI scan. And with arthroscopy, we can make tiny incisions and we can remove these loose pieces with small grasping instruments. Elbow arthroscopy is different than other joint arthroscopies, such as the knee or the shoulder. These procedures are very technically challenging, usually requires specialized training and lots of experience. It's because the elbow joint is so small and there's major nerves and vessels surrounding the elbow, so being able to put the camera in and get these loose pieces requires expertise. This particular process, taking loose bodies, is one of the most satisfying orthopedic procedures we can do. The rehab is so accelerated, you get your motion and your strength back within days and weeks, and the outcomes are excellent. And as you can see in our athlete, this is after her procedure. She is back and continuing her career without injury. This is a 12-year-old gymnast with lateral elbow pain who's had locking, catching, and loss of sensation. And her MRI scan shows she has this loose piece that we take out, similar to our prior patient. But differently, this patient has an area of compromise to the capitellum. That is, there's a defect for when the loose piece broke off from that needs to be treated. We use specialized instruments to remove any other loose fragments so they don't come out in the future. And then we stimulate this defect to heal by drilling holes in the bone. What this does is it allows the marrow elements of the bone, the bone marrow and the blood, to have access to the defect. The bone has the stem cells, and the stem cells are what allow healing, and that creates fibrocartilage. But for some defects and for some athletes, the defect is either too big or there's too much force on the area. The fibrocartilage won't work, and that's when we can do an osteochondral transplant. This is a technique that we developed. The patient is first set in this position and undergoes arthroscopy, and all the loose fragments are removed. And you can see in this situation, it's an enormous loose piece from the capitellum. So we proceed by doing a very small open incision, gain access to that capitellum, we make a socket by drilling into the bone, and the socket's going to be the recipient of this, an osteochondral allograft. That is, it has cartilage and bone that's formed into a plug that's placed, press fit into the socket we drilled. And you can see here, this patient has a brand new capitellum with beautiful cartilage on it. Now, there's lots more information on this. The research that we've performed at a medical center is extensive. Too much for this presentation, but if you want to see more, please go to my website. All of the information is there. You can see the website address at the bottom of each slide. Now we'll move to the inside part of the elbow, where we get the UCL injuries, that sometimes even Tommy John surgery. And that's because, especially with that valgus angle and the repetitive force, the tension injury, either acutely with a sudden pop or over time, the chronic injuries that develop and the UCL becomes compromised. This is an example of a physical exam assessing the UCL. First, the patient is placed in this supine position, lying down on an exam table. You can move up with a sliding chair, a stool, place your knee right underneath the elbow. Now you have beautiful control of the elbow. The patient is relaxed, and you can palpate the different structures. Right below the epicondyle, we palpate the UCL. And if it's tender, that suggests a UCL injury. Now we have beautiful control of the humerus, and now we can stress the UCL by supporting the under part of the elbow and now pushing the wrist to the floor and flexing and extending the elbow. We put stress on the UCL. And if that recreates pain, that means that the UCL likely has some level of. Further characterize the injury by doing stress view x-rays. You can see on the left, the x-ray looks normal, but on the right, and that's my hand as part of the x-ray, we stress the joint trying to open it up. And if the UCL is not working, the joint gaps open, as you can see with the red arrows. Typically, we do this in the office now, and we use ultrasound because ultrasound is so much easier and readily available right in the office. We get MRI scans routinely if we suspect a UCL injury, and you can see here the blue arrow is on fluid that has escaped the elbow joint, and that's because the UCL is torn. Now let's talk about treatment. Treatment is challenging because UCL ligament does not like to heal, but we can get improved healing non-operatively with biologic treatment such as PRP. PRP is platelet-rich plasma. We take a sample of the patient's blood, spin it in a machine, and we extract the platelet-rich plasma, inject it using ultrasound, as you can see here, where we localize the needle right into the ligament, inject the fluid. You see the needle coming in on the left side of the screen. The bump on the right side is the epicondyle, and just below that to the left is the ligament. You saw the fluid of the PRP going in, helping the ligament to heal. So on the inside part of the elbow for gymnasts and also the tumbling athletes, such as in competitive cheer and other acrobatic sports, that it often requires surgery. And this is Tommy John surgery. To illustrate what this procedure is like, here's an elbow where we're making the incision over the inside part. We dissect the tissues in the subcutaneous fat, protecting the nerves that are underlying the skin. And then we gain access to the flexor pronator mass. Once we have access to the flexor pronator mass seen here, we make an incision in the flexor pronator mass, and then we divide the muscle tissue, place appropriate retractors, and this exposes the ulnar collateral ligament. Then we incise the ligament, and we see if the ligament is damaged. This is what it looks like. The ligament is just above my finger to the right, and we're drilling tunnels. The tunnels are going to be used to do the reconstruction. Those two tunnels converge. We connect it with an instrument called a curette. And in some of our gymnast athletes, we make very small tunnels compared to the larger baseball players. And then we create tunnels on the humeral side. This is the humeral epicondyle. We make a socket, and then we create two tunnels, and we pass a graft around those tunnels. This is a palmaris longus, a tendon from the wrist. We can also use a tendon from the knee called the gracilis. And with appropriate sutures pulling on the graft, it gets docked into the epicondyle with excellent tension. And this is going to be a beautiful reconstruction, allowing this gymnast to get to playing and training. Now let's talk about advancements. It takes somewhere between 8 and 12 months for a Tommy John type surgery to be fully healed. But in 2018, we can do a different operation if the patient is a candidate. We can do a repair with an internal brace. We do the same approach to the ligament by incising the fascia of the muscle, moving the muscle to expose the ligament. And in this situation, we incise the ligament. You see the opening of the ulnar humeral joint with the right arrow, but the ligament quality is overall good. It just happened to be peeled off or avulsed from the setting. We can do a repair where we drill a hole in and we place a suture anchor in sutures, and we do a repair without reconstructing or bringing a new graft in. And then what makes this surgery even more strong and allowing for accelerated rehab is we place another anchor in, and we use this tape that's coated with collagen. It looks like a shoelace. It's extremely strong. It spans the top of the native ligament, protecting it. It's like having a brace that would be on the outside of your elbow, but it's located on the inside, and it enhances the healing and allows for accelerated rehab. Now, the final condition I want to move to is a medial epicondyle fracture. And many of our young athletes who are still growing, they can pull the growth plate off because the growth plate is the weak link. So that tension on the inside with the repetitive tumbling will pull the apophysis or the growth plate off. They'll feel a sudden pop, immediate pain. The issue with this, if it's not recognized quickly with either x-rays, MRI, or CT scan, this bone that you see here that's been fractured and displaced will not heal properly, fill with scar tissue, and it's very hard at a later date to get this cured or corrected. So we recommend early reduction and fixation. It's a very simple operation where we put a screw in, anatomically reduce it, and then it goes on to heal. And this situation is most favorable to getting. So elbow injuries are problematic to gymnasts. They're unique injuries. They require specialty care because the challenge is diagnosis and correct treatment. This is my email. If you have a gymnast athlete that you would like to discuss, simply email me. I'd be happy to help you take care of these athletes. And in fact, many of these athletes have amazing demands, and I frequently go to gymnastics facilities to see athletes who are injured and see how they get back and make sure that their return to training and competition is appropriate. Thanks for your attention. Look forward to hearing from you.
All right, great. Thanks so much, Dr. Ahmad. Now we're going to transition a little bit up the kinetic chain up to the shoulder, where we're going to have Dr. Amanda Till, one of our sports physical therapists at Columbia Sports Physical Therapy, who's going to be giving us some rehabilitation pearls in the multi-directional instability of the shoulder. So we'll turn things over to Dr. Till.
right. Hello, everybody. I'm Amanda Till. Like Dr. Lynch said, I am one of the physical therapists here at Columbia Sports Therapy. I am also a physical therapist for the USA Rhythmic Gymnastics team. And personally, I grew up doing dance competitively, and then also I was on an acrobatics and tumbling team while I was in PT school. So today I'm going to be talking about multi-directional instability of the shoulder in gymnasts. So just quickly, little overview, I'm going to talk about what it is, factors to consider in the rehab program, current literature, and then also a rehab protocol. So multi-directional instability is defined as symptomatic laxity in two or more directions, one of which is inferior. And in a research article here, it kind of showed that the incidence of atraumatic and traumatic shoulder injuries in gymnasts is higher than previously recognized. So just a few signs and symptoms, pain and instability with pushing, pulling, or carrying heavy objects. There can be pain during or after exercise. It also has a feeling of the shoulder kind of slipping in and out. A lot of athletes will say it just doesn't feel like my shoulder is in the right place. Fear of putting the shoulder in certain positions. Also, they could have numbness and tingling into the arm, and also weakness with performing athletic movements, especially overhead and away from the body. So just a few different factors to consider in the rehab program is that onset of pathology and the degree of instability. As Dr. Desai sort of mentioned before too, there can be traumatic events or atraumatic events. Today I'm going to focus a little bit more on the atraumatic event, just because MDI can be sort of over time, just that repetitive micro trauma to the shoulder. Also, I'm going to be going over concomitant pathologies. So labral tears are also common in the unstable shoulder. So you also want to consider that, if they do have a labral tear, also with their multi-directional instability, rehab could be a little bit longer just because you want to allow those tissues to heal. Also, end range neuromuscular control you want to consider, as a lot of research studies actually have shown individuals with significant laxity exhibit a decrease in proprioception compared to patients with normal laxity. And then also you want to consider their premorbid activity level, what type of gymnast are they and what do they want to get back to, if they're looking down the elite level or just more recreational. All right, and then Dr. Desai also actually mentioned this a little bit. There's artistic gymnastics, there's rhythmic gymnastics, there's acrobatics, and there's the other ones that she mentioned as well. Artistic gymnastics is going to be more of the focus, just this has a little bit more impact, and there's a little bit more force going through the shoulders, especially with inversions such as back handsprings and round-offs. And also, as you can see, the guy on the rings here, putting a lot of stress through the shoulder joints. All right, and then just a lot of common muscles that you see involved in gymnasts when they're performing such inversion types of exercises or skills is a lot of the back muscles are, your traps, your lats, your rotator cuff muscles, rhomboids, the levator scaps. And then also along the chest, you have your serratus anterior, your pecs, and deltoids. And then also you have your tris, bis, and the coracobrachialis. So just current literature, they say it's well described actually in overhead athletes, but not so much in gymnasts because they're kind of a unique type of overhead athlete. In a research study here in 2008, looked at MDI in elite gymnasts. And so they kind of wanted to look at like the incidence and whatnot. So they found out of almost 500 gymnasts who returned the questionnaire, 22% suffered traumatic shoulder injury, almost 60% reported shoulder pain. And then they found that the incidence rate of people that met MDI inclusion was 11%. And surprisingly, out of all the potential risk factors, the only shoulder pain had a statistically significant association with MDI. And then here you can see they kind of looked at shoulder stretching and hyperlaxity signs. And really the only significant value was the shoulder pain with associated with MDI. Also just current literature. So I'm going to be sort of reviewing the Watson Rehab program, which kind of really focuses on the multi-directional instability. There's a research article that took 43 patients through a 12-week exercise program. The visits were once a week, and the results actually showed functional improvements. This was from 3 different instability questionnaires. It showed increased scapular upward rotation at rest and in early abduction, and also increased shoulder muscle strength. So just a quick little overview. I know it's a lot of words here, but kind of the overall gist of the Watson MDI program is there's 6 different stages it takes you through, and each stage kind of focuses on the scapular phase, just getting stability, centering that humeral head, and then you get more into the arc of motion phase where you start to range the arm as you're keeping that scapula nice and stabilized. So here's just another picture of just another second stage, and you can see the one resistance band shows little resistance for the scapula, and then also he is performing external rotation. As we go along, you can see to stage 6. Once you get to stage 6, that's when you can start to progress a little bit more past 90 degrees. And that's when you get into the more sport-specific phase. So in this case with the gymnast, it'll be more closed kinetic chain exercises, really starting to put weight through that upper extremity. This is just a quick little study. It looked at muscle activation in individuals with MDI. You can see here the lines with the boxes shows the patients with MDI, and the dark diamonds show the controls. So it just shows, actually, surprisingly, the deltoid muscle didn't have quite the same activation as stable shoulders, and the rotator cuff muscles actually were pretty similar to both, the controls and people with MDI. So just a quick little recap, the first acute goals, you want to decrease that pain and inflammation if they're very inflamed. You want to improve proprioception, active joint reposition drills. These braces actually have shown to be very beneficial early in the rehab. And again, going over, you want to gain the control, run, 0 to 45 degrees of abduction, and then you can start to really develop the more posterior muscles. And as you, again, start to progress, you can go more into 90 degrees of elevation. You also want to progress into flexion as well, because especially in gymnasts, in order to perform back handsprings and backward tumbling, you want to be able to get the arm up in that flexion position. And then also develop those deltoid muscles while maintaining scapular control and humeral head control. And then that's when you get more into the sport specific. So you can see that later focus, technique is a really big part of it. You want to minimize the risk of re-injury. Usually a maintenance program is recommended. We have a couple quick drills here. So this is showing just shoulder shrugs and handstand position. You can see the one on the end has pretty good form. The other ones, those hands should be forward for a good shoulder position, and just pushing up and down into that shoulder joint. Also, we have handstand rebounds here, so you want to get in that straight body handstand, snap the legs down, and really just push up shoulders as you're going up and down. And then also on the right, you have other shoulder drills you can do, pushing off a wall, which is a little bit more basic before you get into that inversion position. And that is it. Thank you very much, and I look forward to the Q&A section.
Fantastic. So now we're going to transition to back injuries in the gymnast. We're going to have Dr. Ron Lehman, who's the head of the Athlete Spine Center here at Columbia University. He's going to be going through this here. So Dr. Lehman.
Great, Dr. Lynch. Good evening, everyone. So today we'll talk about a few different things, including some cervical spine issues and the more common lumbar spine issues, as well as we'll touch on scoliosis, which is often spoken about. We know that some spine injuries in the gymnasts are incredibly important. Roughly 11% of gymnasts end up having pars defects at some point, with the incidence of low back pain of between 65 and 80%. Many studies have shown that this to be an issue, including several studies out of the Olympics dating back from 2008. And it makes a lot of sense with all the issues, especially with some of these positions that the patients are placed into, especially with thoracic kyphosis and then anterior pelvic tilt. Many different ways we use to evaluate these, including x-rays, MRIs when appropriate, and we'll go over a little bit of this stuff later. Various activities leading to injuries include these hyperextension and axial rotation injuries. You can see these different activities listed here, all of which are quite significant. So let's start with the cervical spine. One of the things that's the most concerning is cervical myelopathy. This is really essentially pressure on the spinal cord and can certainly result in things like stingers and hemi-quadriparesis or transient quadriparesis, which really renders someone unable to use their arms or legs for a little while. MRI is really the hallmark of this, but once again, physical exam is important. Here's an image of an MRI. You can see on the left-hand side with the brain being at the top and loss of CSF fluid or cerebral spinal fluid in front of and behind the spinal cord. In this particular patient, if they come in with an MRI like this is someone that we'd have to hold out of competition. More concerning is this MRI, where you can see that white spot within the spinal cord, and this is called spinal cord signal change. So certainly anyone doing a tumbling type of activity or certainly a collision or contact sport would not be permitted to play. And we have various criteria that we use now in terms of returning these athletes to play. These are some of the relative contraindications, especially when someone could suffer a fall. You can see, once again, there's various cord compression as far as the MRI and how we evaluate these particular patients. In the low back or the lumbar spine, back pain is incredibly common. So like we talked about before, nearly 80% of athletes have low back pain at some point, and 10% really have and suffer from significant low back pain. Some of the more common injuries include these. We're going to focus a little bit on the herniated disc and spondylolisthesis and spondylolysis, as these are something that's incredibly prevalent in gymnasts and something that we treat very commonly. The physical exam is incredibly important. It certainly can be limited in range of motion. There's some issues with pain with flexion especially. Strength oftentimes can be normal, but sometimes with spondylolisthesis particularly, you can have weakness of the EHL or the great toe. A positive straight leg raise test where you extend the right knee or the left knee, resulting in pain that goes down the leg, can be significant and consistent with a disc herniation. Degenerative disc disease, though, somehow is significantly induced in athletes. In younger patients with this, as you can see on the left-hand side, with significant collapse of the L5-S1 interspace, as well as a herniation in the middle MRI, can be very debilitating. Here's an example of a large disc herniation at the L4-5 segment. Oftentimes these patients have significant leg pain, usually minimal back pain that usually gets better, but also can have numbness and then weakness, most commonly of the big toe or of the ankle dorsiflexors. We also know that if we can wait 3 months after the diagnosis of a disc herniation, nearly 3/4 of patients can improve significantly without the need for surgery. So once again, we use a lot of non-operative care to see if we can hold someone out till at least 12 weeks before we consider doing any type of operative intervention. The treatment, though, however, is most commonly physical therapy, focus on core strengthening, as well as nerve root injections and microscopically assisted discectomy if indicated. Some of the basic indications or significant indications include progressive weakness, which is one of the things that if it doesn't improve by 12 weeks, we really need to consider. Here, once again, you can see a very large disc herniation, L4-5, in a young athlete, which had to be removed with a microscopically assisted discectomy. So here you can see we used a minimally invasive approach with tubular retractors. And on the left-hand side, you can see these are the retractors that go down to the disc space itself. And here's a nice view of the microscope. You can see through the tube with the nerve root being retracted and the large disc herniation being taken out in the upper right-hand corner. And all this can be done through about a 1-inch incision, which is really the size of a quarter. And the return to play and return to sport is quite good. One of the great things we've done at Columbia is with the help of 2 of our therapists, Lorraine Mitchell and Ed Callum, is we've directed and really dedicated physical therapy protocols for many of these routine and general conditions. And you can see here, these are quite extensive. These go through really 4 phases using cross-training to get all athletes back, and I think it works quite well. And we're happy to give you copies of this. If you want to email me at the end, my email will be on the last slide. And I think these therapy protocols are incredibly beneficial. We'll also talk about now spondylolysis and spondylolisthesis. These are one of the few things that's very classic with gymnasts, and we see a lot of these and treat a lot of these, and I'm going to unfortunately have to do an operation on a young gymnast on Friday. So spondylolysis is whether there's a fracture or defect, as you can see in the red on the top-hand side. Once that defect ends up propagating or elongating, it can result in spondylolisthesis, which is slippage of the vertebral bodies. Some of the things that are common with these is they're actually a little bit more common in male athletes. Certainly in divers, gymnasts are incredibly common as well, and oftentimes affect the L5 nerve, which is the most common nerve affected, also the L5 vertebral segment or posterior element. These patients will have chronic low back pain, which can be increased with extension. Here's an example of an 8-year-old gymnast with low back pain that fortunately resolved. You can see the significant slippage of almost a grade 2 here as the L5 vertebral body slipped on the S1. And the more concerning one is here, where you have more than a grade 3 spondylolisthesis, and these all require surgery when they're more than 50% slipped. We do a couple things in terms of workup, certainly history and physical examination, how the person's performing, and then we look at getting MRIs, CT scans, and SPECT scans. Here's an example of a CT scan, which you can see in the white arrows in figures C and D, which shows the fracture itself. And here's an example of a SPECT scan where you can see where it's hot, which is uptake here in this particular patient of the L3 segment. We look at these in various ways. When they're hot on SPECT scan, there's no sclerosis, and this is a typical treatment is rest for 2 to 3 months. When the SPECT scan is cold, this is when the patient can resume activities depending on the treatment. Also, what we try to do is there's a minimal chance of defect healing, certainly in the college-age athlete. If the symptoms are the same as any other back injury, we really want to treat it as such, with rest and activity modification as well as physical therapy. I generally start patients off with a Tlso or a brace for about 2 months. We then see how they're doing. If they have no back pain, we let them slowly return to sport with the guys under the guise of physical therapy. If they still have pain, we then do it again for 2 months. And surgery is really a last resort where we can often repair the pars without having to perform a fusion. In cases where there's significant listhesis, we sometimes have to actually fuse that segment. And here's an example of the typical operation that I perform. In black there, that's the pars defects, which is a yellow type fibrous tissue. We can then decorticate this area, fill it with bone graft, all through a microscopically assisted tubular MIS approach. And then finally, we can place a screw as well as a hook over the segment to help treat the fracture itself without having to fuse the segment. And here's an AP and a lateral radiograph of a basketball player, Division I athlete that I performed just last year. And once again, with the help of Ed and Lorraine, we developed these protocols for both non-operative and operative treatment of spondylolysis and spondylolisthesis. So let's finally touch on scoliosis. The incidence of scoliosis is 10 times higher in gymnasts. So roughly 12% of gymnasts can end up developing some form of scoliosis. And the triad of joint laxity, delayed maturity, and asymmetric spinal loading are key. And you can see in the figure on the right-hand side with this pelvic cross syndrome, there's many different forces that are obviously placed on these athletes. Scoliosis is really defined as lateral curvature of greater than 10 degrees. The curves can be both thoracic in the chest or in the lumbar spine. Treatment for curves less than 25 degrees is to observe. From 25 to 40 degrees, we place the patients in a brace called a Tlso, and then oftentimes we add Schroth physical therapy to this to help assist with the brace treatment. Curves greater than 45 or 50 degrees generally require surgery, especially if the patient is skeletally immature, because these curves will continue to progress into adulthood. And you can see some of the things we do. We often prescribe, like once again, we talked about the Schroth physical therapy. And here's an example of a brace with the patient in it to help correct the scoliosis, all of which are tried to maximize in terms of non-operative care. Oftentimes at this point, we can let curves go quite large, 60 or even 70 degrees, before offering operative treatment. So if someone's going to play or participate in gymnastics as a high school student, or certainly as a college or Olympian, we can often delay these even into the 20s. Here's an example of a patient that I did this particular surgery on, scoliosis of about 52 degrees. And you can see with this type of construct, we can correct the scoliosis quite well. And we can then allow almost all athletes to return to sport, including collision and contact sports, at 6 months post-operative. And here a long-standing film from both the AP and lateral perspective. So we also published a study, as most patients and their family members are interested in when can patients return to sports, even after scoliosis surgeries. And so for the selective thoracic fusion, the case I just showed, really any sport, including collision and contact sports, we allow teenagers to go back at 6 months post-operatively. But this is really a multidisciplinary approach. Certainly all the talks that you've heard and then the ones that are coming, it takes all these people into account to be able to help treat some of these very common gymnastics-related injuries. And this is one of the things that we really try to specialize on here at Columbia, especially with the spine care. Thank you.
All right, fantastic, Dr. Lehman. We're going to transition now to Dr. Taka. We're going to go from the spine down to the hips and the knees. Dr. Taka is one of our newest recruits who's going to be joining me with our Hip Preservation Center. He specializes in joint replacement and preservation procedures. And without further ado, we'll turn it over to Dr. Taka.
Good evening. Thank you for joining us tonight. I'm excited to talk to you about some hip problems in gymnasts. No relevant disclosures, just a quick overview. I think you're going to hear some common themes from my presentation tonight from the things you've heard earlier. And we'll go through, primarily be focusing on hip tonight and not so much on knee, and we'll start with the background here for gymnasts.
Dr. Taka, if you wouldn't mind showing us your slides, that would be great.
Oh yeah, that would be helpful. There we go. Is showing up?
You're all good.
Perfect. So like we heard earlier from Dr. Desai, many of these athletes are very young. It's a very rigorous training, and they're extreme range of motion requirements, and in particular, these put the hip at risk for what's called femoral acetabular impingement, which we'll get into earlier. As was mentioned earlier, tissue laxity can be a big concern. And one important distinction is soft tissue laxity that you are born with versus mobility or hypermobility that you develop through training. And oftentimes, someone with even normal or it's considered normal tissue laxity can dip into the hypermobile range, and this will be affected by hormones as you develop, as well as affect recovery. So hypermobility is something that a gymnast wants because it makes you a better competitor. Unfortunately, it puts you at risk for impingement. So what is impingement? Here's a quick video that I think demonstrates what impingement is. Basically, it's when you have the acetabulum or the socket of the hip contacting the femur, or in this case, the femoral neck. And this happens in any human being. However, because gymnasts are continuously going through these extremes in range of motion, this happens more frequently, and it can lead to secondary problems. So what are the causes of impingement? Obviously hypermobility, as we talked about, but another important concern is if there are any anatomic abnormalities. Some of these anatomic abnormalities are developing or abnormalities that you develop over time, and some are things that you are born with. So what is femoral acetabular impingement? We saw the video, and just some more distinctions. It can happen on the acetabular side, as we can see in the pincer quadrant, or it can happen on the femoral side, as we can see on the upper right quadrant and the cam quadrant, or it can happen on both sides. So how do we treat it? Here's a video of a patient with a cam lesion. Hopefully it's playing. And here you could see there's this cam lesion, and you could see clearly that it's displacing the labrum and causing impingement for this patient. So returning to these slides, the other side that can cause problems is not only the femoral side, but the acetabular side, as we saw. It can also be too prominent, and it can also be too shallow. And when it becomes too shallow, which is called dysplasia, the femoral head no longer can sit concentrically inside the socket. And what can happen is it can actually shift out, and it can hit the labrum right on the edge of the acetabulum there. And when the labrum becomes a weight-bearing structure, which was not designed to do, it's a gasket that holds in the joint fluid that lubricates your joint, it becomes pathologic and painful. And the third thing that can affect impingement is actually the rotation of your femoral neck, and we call this femoral version. On the left, you can see this is what a typical femoral version is. However, many athletes over time can develop a new version, or they can be born this way where they have increased anteversion or even retroversion, where the neck is pointing in a different direction. And what this influences how soon and where the femur and the acetabulum connect to impinge. So one thing that's often very difficult, and why there's been so much progress in the field of hip surgery and treating hip pathology over recent years, is because there are so many things that can present as hip pain, or what patients feel as hip pain. Some of the things we heard about tonight, like lumbar disease, but there can be even abnormalities in your pelvis or in your GI tract that can also affect these and be interpreted as hip pain. Here's a paper I stole from Dr. Lynch's, or here's a slide I stole from Dr. Lynch's paper that he just recently published in JAOS Yellow Journal. And here's a very easy flow chart to understand of how we go about treating these hip problems. So most commonly, a patient presents with groin pain. So first, we rule out any of these other diagnoses, such as lower back pain, bowel, bladder, reproductive system issues. And depending on how certain we are on our physical exam and the history of the patient, we either proceed to advanced imaging, including MRI, ultrasound, even CAT scan. Or if something becomes apparent, then we usually do a trial of non-surgical treatment. Occasionally, we can do injections, and from there move on to surgery. So how do we examine a patient? Commonly, if the patients don't have groin pain, they do what's called the C sign, where they place their hand over the lateral aspect of their thigh in the shape of a C. Things that we check are strength, as well as the range of motion, both supine and prone. And the reason we check both is because asymmetry in the prone position can give us clues as to the femoral version. Here's a very common exam. What we saw in that video earlier was impingement, and the most common area where this occurs is the anterior superior portion of the acetabulum. And in order for that to happen, typically the hip is flexed, it is adducted, and internally rotated, as you can see in this position. And it's very common for patients to have pain in this position. Another position that can be uncomfortable for patients, depending once again on their anatomy and what pathology is going on in us quite different position where you're flexing, abducting, and external rotating. This can actually be a sign of posterior impingement or what's called an inside-out lesion, where the femoral head is actually hitting the labrum from the inside and not from the front. And lastly, here is another posterior impingement test where we externally rotate the leg when the patient's leg is hanging off the end of the table. And this gives us some more information about the posterior side of the acetabulum. So how do we treat patients? Obviously, we have many modalities, beginning with physical therapy, which we discussed earlier for other joints, obviously is applicable to the hip, and medications. We use injections as well. However, to me, injections are more a diagnostic tool and a temporary fix. If a patient comes in and says, I have a competition next weekend, I just need to get through, then I think an injection is appropriate, but it's definitely not a long-term solution. I think something Dr. Lynch can talk about more at some point, but this is his primary specialty is arthroscopy. It's an excellent way to address both extra-articular and intra-articular pathology in the hip, because they can address both soft tissue and bony abnormalities. However, there are problems that cannot be addressed solely by arthroscopy, and you can do a combination of arthroscopy and open surgery, or just only open surgery. This is a surgery that I perform more commonly. It's called a surgical hip dislocation, and here's a video from a surgical hip dislocation showing what the cam looks like after it's been resected, and we can see that the patient no longer has that impingement as much. The labrum is no longer being displaced the same degree, and the femoral head and neck fit much more congruently in the joint. One other surgery that you can do for a shallow acetabulum, here on the left side, you can see another illustration demonstrating a shallow acetabulum, is what's called a periacetabular osteotomy, or it's called PAO for short. And what we do is we cut around the acetabulum, and we are able to orient it in a position that's more biomechanically advantageous. And one of the biggest benefits of this surgery is that after completing a surgery like this, an athlete can go back to doing everything they were doing before after a few months of recovery, as opposed to requiring a prosthesis or some other more major surgery. And that's where my talk will end this evening. So thank you very much for listening.
All right, so we'll have everyone, all of our speakers come on for our question and answers here for the next 15 to 20 minutes. We have Dr. Taka here, so I'll start with him. I think you did a great job of kind of laying the foundation that, these issues are multifactorial. Some of it is based on their soft tissue laxity, some of it's based on the architecture of their pelvis, some of it's just how the good Lord made them. How do you counsel patients who come in with radiographic findings but with minimal symptoms, and kind of guide them as to how to appropriately manage this? More times than not, won't need surgical intervention, but how do you guide them through that, and what do you look forward from a physical therapy perspective for them?
I think one of the biggest tenets that I'm sure all of us learned during our medical training is you treat the patient and not the x-ray. And unfortunately, we don't have a crystal ball, and it's very difficult to anticipate a problem in the future. So depending on how well the patient is progressing with their activities, I think physical therapy can be a very effective option for many patients. However, if the pain remains persistent, I think sometimes surgical intervention may be necessary to preserve the hip so that they can continue doing what they love to do.
Yeah, one thing that I see in my practice a lot is patients getting very concerned about an MRI report that shows that they have a labral tear. I'm sure our spine colleagues feel the same thing about a disc herniation. And the one thing that I do counsel them on is that, there was a study that was done a few years ago where they looked at people from 15 to 65 years of age, and what they found was that 70% of those individuals with no hip pain had a labral tear. So as you said, I think that's a point well taken, is managing the patient and their symptoms and not their MRI report. So Dr. Lehman, wanted to touch base with you, in between the connection of the hip and the spine. I think there's more and more research that is now coming out looking at the connection between the two. And what are what are some things that you look at when you're evaluating these patients and for our group?
Yeah, I think it's a great point from that perspective, because one of the things that certainly happens. Sorry, 1 minute. Is that bad timing for the question?
Yeah.
One of the things that happens, especially when we see cases like spondylolisthesis and things that affect, particularly the L5 nerve, we certainly see a lot of issues with peritrochanteric issues where the muscles, especially the abductors, tend to get weak. It doesn't happen as much in the younger athletes, but certainly the more chronic players from that perspective. I think it's really important to help differentiate spine from hip issues. And so, we publish now quite a bit on the hip spine syndrome because, as you're pointing out, most typically groin pain or pain in the front of the hip is more typically going to be intra-articular hip pathology. But when you get to the lateral aspect of the hip or posterior aspect of the hip, it's a little bit of a dealer's choice. And so I think certainly performing a pretty thorough exam in terms of neurologic deficit, in general, things like sciatica and disc herniations don't sort of really, if you press on something and it hurts, it's typically not a radicular type of component. And so I think that's one of the basic things that you can help differentiate. We certainly talked about before, straight leg raise testing, femoral tension signs. Those are things consistent with disc herniation. Things like spondylolisthesis, pain with extension, which is obviously a very common thing with gymnasts, also helps differentiate some of these things from the hip versus the spine. And certainly understanding how to do a pretty thorough hip and lower extremity exam. Certainly one of the benefits of being an orthopedic surgeon is that when I evaluate patients, at least several times every office, I have to evaluate someone's shoulder or someone's wrist or someone's hip from that perspective, because there's a lot of crossover. And so oftentimes it's really good to be able to see, multiple providers, because some of these things are very difficult to sort out, certainly before you think about doing anything more invasive.
Yeah, I think those are points well taken. I can tell you, a month doesn't go by that I'm not diagnosing a disc herniation for someone who's coming in with hip pain. So Dr. Till, question for you here. When you're evaluating one of your rhythmic gymnasts, can you kind of give us some pearls as to, what are some things that you are looking for, aside from just multi-directional instability, what you talked on, but just kind of like your global evaluation of these athletes, and what are some things that you can help our audience to look out for as well too?
Yeah, sure. Do I have to do anything to make my screen bigger, or are we good?
I think you look good.
Okay.
Yeah. Well, your screen looks good.
So yeah, with rhythmic gymnasts, they need a lot of ability. They're very flexible. A lot of them, they typically have like repetitive injuries, mostly like the low back, and then sometimes shoulder, because rhythmic also involves a lot of tossing. They have like their hoop, they have ribbons, so it does involve some throwing. So sometimes they'll have some shoulder injuries. We look mainly at stability, again, because hypermobility is a main concern. So we kind of take them through a couple different tests, more endurance types of tests. So like side plank is a big one. Also side plank with like lifting the leg up, so it's a little bit more functional or sport specific. Other than that though, it's usually the spine we look at, because they are arching, their back bends, they're all the way back touching their legs. So usually it's just more overworked muscles, and it's actually surprisingly weakness in their trunk musculature, just because they are so bendy and flexible. So typically, we want to look at planks. And then I would say also another big thing that we see a lot in rhythmic gymnasts is hip flexor, tight impingement, and, a lot of snapping hip issues. So that's usually another thing. And usually because they have to hold their leg up there. So if their cores are weak, they're going to be kind of overusing that hip flexor muscle.
Okay, great. Dr. Desai, anything from your perspective in terms of the evaluation of these athletes for our audience?
So what, I kind of touched on it a little bit earlier, is that the strength through the range of motion. So I think what Amanda said is exactly right. You not just checking the range of motion and seeing if there's pain throughout it, or it's actually holding. A lot of times that you see them fatigue, and so things like scapular dyskinesis, holding their arms up in those awkward positions that they tend to keep their arms in. You could see that over time, a couple seconds to like 30 seconds, you could see that their scapula starts winking. And same thing with holding their leg up. You can see that they start tucking their pelvis using their hip flexor. And so that's definitely part of it. The other thing is just a really good history, kind of what actions actually cause pain. And so taking into account what training that they've recently done, like I said, are they in season or out of season, and all of that. So I try to take into the whole clinical picture in addition to their actual clinical exam.
And I have another question for you in terms of, we talk a lot about, some of the injuries are traumatic, but many are overuse, and the role of stress fractures and stress reactions, injuries, whatever you want to call it in this population. How do you gradually get them back? Because, some of the videos that you showed, there doesn't look like there's a lot of low stress that's going on with any of the maneuvers that they're doing, whether it's the low back or lower extremities.
Yeah, I mean, gymnastics is, especially when you get at the higher levels, you create your routine. So there is ways to kind of get around certain types of injuries. Quick story, Mohini Bharadwaj, my favorite gymnast in the world, she dislocated her elbow. She had to compete at one meet. She did a whole different routine that she never put her elbow down once. I mean, obviously she's an Olympic gymnast, but basically adjusting the routine is part of the options, but we do a stepwise fashion. I have a whole protocol that I do for both upper extremity and lower. The first protocol with the same throughout the range of motion, getting the actual physical time that it takes for the bone to heal, or the growth plate to heal. And then once we've determined that the actual bone and growth plate has healed, then we take them through a slow progression to sport. Usually that can take a couple of months till they're back to full sport. But the big part is, in that progression, is try to correct whatever compensation that may have led to the injury in the first place, or try to slow them down and see if there's any areas that we can reduce their susceptibility to injury.
Great. And then let me just ask you, you specialize in concussions, and do you see anything differently in terms of the concussions that this this athlete population has as opposed to football players?
I think concussions actually go underreported in gymnasts because they tend to hurt their lower extremities, their arms, their backs. But there's plenty of times that you can imagine how when kids are flipping through the air, if they miss their feet, they could fall back and hit their head on the ground, or even on the equipment when they're doing release moves. Like I said, in my talk, concussion eval is going to be the same. That you look for the same vestibular insufficiencies, you look for the symptoms, you treat them the same, in that you withdraw them from the activities that cause the symptoms. But it is something that we really have to pay attention to into progression back to sport. We already know there's been multiple studies that there's an increased risk of lower extremity injury after concussion. And I think that's probably because of some vestibular insufficiency that's still recovering. And so you can imagine, it's a lot different running on a soccer field than trying to tumble on a 4-inch wide balance beam. So we really have to be sure that their vestibular system is fully recovered before we let them go full go in gymnastics.
Got it. So Dr. Lehman, I got a question for you. So when you have a patient come into the office, are there any predictive factors when you're evaluating them that you can tell if someone's going to be successful or not successful for management of a spondy or a disc herniation, that you can be able to guide them, if this is something that you might want to be more aggressive and just take care of, or something that you think they'll be more successful with non-operative care?
Yeah, I think there's certainly a couple of red flags. The biggest red flag, I think, when it comes to especially with disc herniation, is someone if they have a foot drop. And so if someone comes with a foot drop with significant weakness, really limited dorsiflexion, no EHL whatsoever, that's probably the rare case that I would think about intervening earlier in terms of a surgery. Really for spondies, for back pain, for disc herniations, we really try to do a very similar approach. And so essentially everyone gets prescribed a Modification dose pack to start, as long as there's no contraindications. We get them into physical therapy with one of our rehab protocols. And then depending if they have significant leg pain, oftentimes we'll get them a selective nerve root injection to help decrease the leg pain. And I see them back pretty frequently, because if someone, like I said in my talk, about 73% of people will improve by 12 weeks. And so we know that some of these disc herniations, if we do surgery very quickly, they'll get better. But if we can hold them out for 12 weeks, they'll get better without surgery. And so ultimately, that's the best thing. If you can avoid surgery, the better. Spondies, it's the person who has significant pain. And I've really seen spondies or at least lysis at almost every level, including the thoracic spine, particularly in gymnasts. And so if you don't have a neurologic deficit, meaning typically it's EHL or dorsiflexion weakness, those patients most typically get back. It's only about 2 to 3% of everyone I see with a spondylolysis that ends up needing surgery. So very, very rare from that standpoint.
Dr. Taka, kind of a question in the similar vein. If you have a gymnast or an acrobat athlete who's coming in with hip discomfort, kind of what are some things that you are looking for, or some things that you think might be pushing you more towards surgery, just kind of in your own mind, that you can kind of guide some of our therapists and ATCs to be on the lookout for?
Obviously, as we talked about before, persistent problem. I think one thing I've heard you say before is that a labral tear, these other injuries, tend to be smoke when there's a fire elsewhere. And if you have an anatomic aberration, some kind of pathology, dysplasia or rotational issue, or some kind of cam lesion or pincer lesion, oftentimes it may not be enough to just go through PT to make that go away, because you end up having a true physical impingement there. It's real. It's not in your mind, or it's not something you can really work through. So I think if someone goes through PT and it just remains a persistent issue, then I will definitely evaluate all the diagnostic images that I need to ascertain whether the patient needs any surgery or not.
And then just real quickly, I think for you and I, the difference between a surgical hip dislocation and a periacetabular osteotomy is kind of a very common nomenclature and things to talk about. But for people or for words that they have no idea what you're talking about, can you just kind of briefly kind of give a sense of when you might use a surgical hip dislocation and what exactly a PAO is?
Yeah. So I think the easiest way to look at it is a PAO addresses the acetabular side primarily. And that's a surgery that you do for someone, whether they have a shallow acetabulum or an acetabulum that's actually rotated backwards, which can happen. And then it brings that anterior superior part of the acetabulum closer to the femur. And in those cases, that's one of the best ways to address the acetabulum. And then the surgical hip dislocation, the way that I think of it is it's kind of a bigger gun than an arthroscopy. So if there's an issue that can't be fully addressed with an arthroscopy, whether you just don't have the right angle, and I think obviously you could attest to this more, arthroscopy has come a very long way from hip arthroscopy from its inception. And I think surgeons are doing much more than ever before, but nonetheless, there are certain issues that can't be fully addressed with arthroscopy. And in those cases, I think a surgical hip dislocation would help. And sometimes a surgical hip dislocation is also warranted, even if an arthroscopy would help, because the patient may need an open procedure like rotating the femur if they have an unusual femoral version. And in that case, if you're doing a big exposure, doing a little bit more to do the surgical hip dislocation may be indicated.
Yeah, no, absolutely. And I think from an arthroscopy perspective, it all kind of started about 20 years ago when they wanted to see if they could get the camera inside the hip, and then kind of transitioned from removing some loose bodies to cleaning up or removing part of the labrum and then figuring out that the labrum actually should be repaired and not removed. And now we know we need to shave the bone down. And essentially, aside from a posterior cam lesion, so the video that you showed us, those anterior femoral neck offset issues can be addressed arthroscopically. And unless there's some issue, as you said, to femoral version, we can get most of that done arthroscopically.
Mhm.
So I think we're coming to the end of our time here. I think we'll give everyone just one last word in terms of one pearl for our audience here, and I'll start with Dr. Lehman here. One pearl for our audience in terms of managing or evaluating gymnasts with spine issues.
Thanks, Susan. I think the most important thing is to certainly do a thorough neurologic examination. That's really the thing that, if anything, can sort of get patients into trouble. Certainly when it comes to the back pain, like we talked about, getting them a good physical therapy protocol, anti-inflammatories, rest, the standard things that we do. If someone has a neurologic deficit, it's usually best to get that person to a spine surgeon or non-operative or for non-operative spine care relatively quickly, just to make sure that the physical examination, especially the weakness, is documented. And so I think that red flag is really the biggest concern.
Yeah. Dr. Taka.
I think one of the most important things, going back again to what we learned when we were learning medicine, is a very solid history and physical, because I think a lot of these issues can be at least preliminarily diagnosed with a history, depending on what positions that are uncomfortable, which activities are uncomfortable. So if any of these flexion, internal rotation kind of positions, definitely should be a red flag. And of course, the physical exam, I think, can be a dead giveaway. Oftentimes, at least tip you off to get a further imaging.
Dr. Till.
Yeah, so I would say main thing is a thorough history. Just make sure to, gymnasts are pretty tough, in general. So when, they're complaining of shoulder pain, they feel like that shoulder's, not in the right place. Most likely isn't. So, make sure you, consider that. And then main thing is really just, working on that stability, that strengthening slowly and tolerably. And then eventually, getting them back into those gymnastics drills, but also being a stickler for technique.
Great. And then we'll give the last word to Dr. Desai, who helped to organize our gymnast and acrobat webinar this evening.
So I'm going to go more general. I think the biggest thing to recognize is, like Amanda said, these gymnasts are tough. So encouraging them to get evaluated earlier than later. I think gymnasts have a big fear that if they come see a doctor, they're going to be taken out of sport. So they just avoid them altogether. I think understanding the sport, figuring out ways to keep them involved, keep them practicing while avoiding injuring themselves is key. And is truly valued by gymnasts. So really taking the time to get to know where they are in their sport, and making it an environment so gymnasts are willing to come and get evaluated so they don't worsen their injuries is key.
Well, those are points all well taken. I think, I can't echo enough, the patient will tell you what's wrong. They'll lead you down the path of righteousness. So again, thank you everyone for taking time out of their schedule. I know during the holidays, it's tough to pencil out some time for this. So thank you for participating, and please, you will get a survey, hopefully sometime this evening, from Phil and Chris back from the mothership about our event here this evening. If there's any comments or any areas where we can improve, please just let us know. We're always looking to make these events better. If you have any ideas for topics in the future, please just let us know that as well. So without further ado, thanks everyone on our panel here, and have a great holiday season.
Thank you. Happy holidays.
Thank you.
Thank you.
Thank you.